everyone. My name is Dr. Katie Vaughn from Beth Israel Deaconess Medical Center in Boston. Thanks for tuning in for the next video of Devices in a Dash, the intra-aortic balloon pump series. Today, we are going to discuss a few different clinical scenarios and what patient characteristics would most benefit from balloon pump support. As mentioned in our previous videos, the overarching benefits of the balloon pump are to reduce left ventricular afterload with deflation and improve coronary perfusion pressure with inflation. These effects can lead to an increase in cardiac output and a reduction in left heart filling pressures. The change in cardiac output with balloon counterpulsation varies significantly between different patients, but classically, the cardiac output increases by an average of 0.5 to 1 liter per minute. There are some patients who benefit more and some less. Several observational studies have examined clinical factors associated with a favorable response to intra-aortic balloon counterpulsation. This study from Columbia, published by Dr. Garan and colleagues, demonstrated that among a population of patients with chronic heart failure and cardiogenic shock, there is a large range of hemodynamic response to balloon pump support, ranging from patients with hemodynamic deterioration despite balloon pump support, all the way to super responders who have dramatic increases in cardiac output and reductions in left ventricular filling pressures and pulmonary artery pressures. Chronic heart failure patients with higher systemic vascular resistance and at least moderate to severe mitral regurgitation were more likely to have a favorable hemodynamic response to balloon counterpulsation. Based on several published studies examining characteristics of patients who had a favorable clinical or hemodynamic response to balloon pumping, we have identified some key features of balloon pump responders. We can categorize those features into three pillars: left ventricular dominant failure, reversible left heart congestion, and cardiac output reserve with afterload reduction. This table summarizes some specific clinical echocardiographic and hemodynamic features that have been associated with a favorable response to balloon counterpulsation. We will re-emphasize these features in the cases discussed today. Today, we are going to present three distinct patient scenarios to describe some of the common characteristics that are associated with better or worse response to balloon pumping, and apply the knowledge we've learned in the last few balloon pump videos. So let's meet our first patient. In case 1, Mr. A is a 56-year-old man with a history of chronic dilated non-ischemic cardiomyopathy with moderate to severe functional mitral regurgitation who presented with decompensated heart failure and cardiogenic shock. On presentation, his initial vitals include a blood pressure of 80/58 with a MAP of 65, heart rate of 110 beats per minute in sinus rhythm, and his SpO2 is 93% on 6 liters nasal cannula. He has evidence of significant congestion on physical exam with an elevated JVP and significant lower extremity edema. He has evidence of end organ hypoperfusion with a creatinine of 1.7, up from a baseline of 1.0, elevated liver function tests, ALT 472 and AST 395, and a mildly elevated lactate of 3.0. He is diagnosed with acute on chronic heart failure cardiogenic shock and classified as SCAI Stage C with evidence of end organ hyperperfusion requiring pharmacologic support. In the CCU, baseline echo was obtained and some clips are shown here. Notably, the left ventricle is moderately dilated with LV dimension of 6.5 centimeters. The upper limit of normal for men is about 5.8 centimeters. His ejection fraction is low at 25% and he has evidence of 3+ functional mitral regurgitation. His right ventricular systolic function is mildly depressed. Given evidence of shock, he is started on dobutamine at 5 micrograms per kilogram per minute and admitted to the CCU. He has a pulmonary artery catheter or SWAN placed that shows a right atrial pressure of 10, pulmonary artery pressure of 60/30, and pulmonary capillary wedge pressure of 30. His cardiac index is 1.8 and his systemic vascular resistance is 1222. Pause the video here to think. How would you qualify this patient's shock, right or left-sided dominant? How would you frame this patient's current clinical status? Great, so this patient has cardiogenic shock that is left-sided dominant as evidenced by the disproportionately elevated left-sided filling pressures with elevated wedge greater than right-sided filling pressures. The RA to wedge ratio is 10/30, equal to 0.33. In addition, he has severe functional mitral regurgitation, likely from severely dilated left ventricle. Given severity of his shock, the patient has a femoral access balloon pump placed. After placement of his balloon pump, he has notable improvement in his hemodynamics and symptoms. His repeat hemodynamics are notable for significant reduction in his left heart filling pressures and pulmonary artery pressures, a substantial increase in cardiac index to 2.6 liters per minute per meter squared, and an increase in mean arterial pressure with a significant reduction in SVR. This patient had impressive response to balloon pump placement and would be deemed a balloon pump responder. Some of the clinical features to note for Mr. A that contribute to his robust response to balloon counterpulsation include the dilated left ventricle, a history of chronic heart failure presenting with acute on chronic heart failure shock, the presence of severe functional mitral regurgitation with high pulmonary artery pressures, and elevated SVR. For patients with chronic heart failure, the more dilated the left ventricle becomes, the more sensitive it is to increased afterload. That afterload sensitivity is increased even further by the presence of significant functional mitral regurgitation, which provides a low-pressure pop-off valve for the left ventricle, leading to significant stroke volume being ejected backward into the left atrium. Balloon deflation in the proximal aorta at the time of left ventricular systolic ejection can dramatically reduce the afterload conditions for the LV, allowing much more stroke volume to be ejected forward into the systemic circulation, thereby increasing cardiac output and lowering the left heart filling pressures. With balloon pumping, that afterload reduction is achieved while still maintaining, if not even increasing, the mean arterial pressure and thus not provoking hypotension, which can sometimes occur with systemic vasodilators such as sodium nitroprusside. Now on to case number 2. Miss B is a 40-year-old female with minimal past medical history who presents with shortness of breath and orthopnea 2 weeks after recovery of a viral illness. On presentation, her blood pressure is 80/60, and she is found to be in atrial fibrillation with rapid ventricular rates to 140 beats per minute. She is saturating 90% on 6 liters nasal cannula. She has evidence of severe congestion on physical exam and is diagnosed with cardiogenic shock secondary to severe myocarditis with elevated cardiac biomarkers related to a recent viral illness. On admission to the CCU, she is started on norepinephrine and dobutamine. She has an echo which shows a normal left ventricular dimension of 4.0 centimeters, but the ejection fraction is low at 25%. The left ventricular wall thickness appears mildly increased diffusely. There is evidence of 1+ mitral regurgitation, and the right ventricular function is moderately to severely decreased. She has a pulmonary artery catheter placed that shows a right atrial pressure of 18, pulmonary artery pressure of 46/24, pulmonary capillary wedge pressure of 20, and a cardiac index of 1.5. MAP is 60 and SVR is 1120. She has a repeat lactate checked which has risen to 4, despite the use of norepinephrine and dobutamine. Pause the video here to think. How would you qualify this patient's shock? Right or left-sided dominant? How would you frame this patient's current clinical status? Great. So this patient has evidence of biventricular cardiogenic shock as evidenced by bilateral elevated filling pressures and evidence of low cardiac index. She has SCAI stage D cardiogenic shock from acute myocarditis with evidence of persistent hypotension and worsening hypoperfusion despite initial support with an inotrope and vasopressor. For the sake of discussion, a balloon pump is placed, and given worsened hemodynamics, she is placed on an additional pressor, vasopressin, due to persistent hypotension with a MAP of 55. Repeat hemodynamics show right atrial pressure of 22, pulmonary artery pressure of 48/28, a wedge of 22, and a cardiac index of 1.3, with an SVR of 1015. Miss B, unfortunately, is having worsened hemodynamics and clear evidence of biventricular failure. Due to this clinical trajectory, a decision is made to place the patient on VA ECMO to provide biventricular support. To break down Miss B's case, she was not a good candidate for balloon pump support placement for several reasons. First, there is evidence of biventricular failure, and the balloon pump provides no direct support for the right heart. We'll come back to this summary slide in a bit. For this case, I want to highlight different ways we assess right ventricular contribution to shock, the PAPI score, and the right atrial to pulmonary capillary wedge pressure ratio. Miss B has a high right atrial to pulmonary capillary wedge pressure ratio and a low PAPI score, which suggests biventricular failure. You can use the RA to wedge ratio as a tool to determine if the patient has LV dominant failure, biventricular failure, or RV dominant failure. In this case, the RA to wedge ratio is 18/20, which equals 0.9. There are no perfect or absolute cutoffs for the RA to wedge ratio, but this figure is helpful to provide some general ranges. Patients with RA to wedge less than 0.6 typically have LV dominant failure, while patients with a very high RA to wedge greater than 1.0 often have RV dominant failure. Patients in between, with an RA to wedge of 0.6 to 0.9, often have combined left and right or biventricular heart failure. The PAPI score is calculated by dividing the pulmonary artery pulse pressure, the pulmonary artery systolic pressure minus the pulmonary artery diastolic pressure by the right atrial pressure. The lower the PAPI score, the worse the right ventricular function. A PAPI score of less than 2.0 typically suggests some degree of biventricular dysfunction, and a PAPI score of less than 1.0 often indicates severe isolated right heart failure. A low pulmonary artery pulse pressure with elevated right atrial pressure suggests that the right ventricle has very poor contractile function. The PAPI score for our patient is 46 minus 24 divided by 18, which is 1.2. For Miss B, the RA to wedge ratio of 0.9 and the PAPI score of 1.2 suggests a significant component of RV dysfunction, and taken together with her other hemodynamics and the echocardiogram, we would classify her as having biventricular failure. Since the balloon pump does not provide any direct right heart support, it is unlikely to be helpful in her case. Reviewing our summary chart of balloon pump response, she lacks most of the criteria identifying patients who can respond favorably to balloon pumping. She has significant degree of biventricular shock with significant right and left ventricular dysfunction, and the balloon pump does not provide direct right heart support. The left ventricle is not dilated, there is only minimal mitral regurgitation, and her SVR is not particularly elevated at presentation. As such, she is unlikely to have much improvement in cardiac output with the afterload reduction generated by the balloon pump. Furthermore, she is in atrial fibrillation with a rapid ventricular rate. Balloon pump timing can sometimes be challenging with patients in rapid irregular rhythms. There are different trigger modes such as AFib trigger mode that will help the pump function optimally with an irregular rhythm, but such rhythms can still reduce the hemodynamic impact of a balloon pump. Now on to our third case. Mr. C is a 58-year-old man who presented 4 days after the onset of chest pain and was found to have an LAD occlusion and undergoes PCI with stent placement. The patient was classified as a late presenting myocardial infarction. The patient's course after PCI was complicated by cardiogenic shock and he was admitted to the CCU. Vitals upon arrival include a blood pressure of 70/55 with a MAP of 60 and a heart rate of 110 beats per minute with sinus tachycardia. He started on norepinephrine given his hypotension. There is evidence of end organ hypoperfusion with a creatinine of 2, lactate of 4, and his urine output is only 20 cc's per hour. Echo on arrival to the CCU shows a left ventricle with normal dimension of 4.5 centimeters and a reduced ejection fraction of 20% with an akinetic anterior wall and septum. There is evidence of trace mitral regurgitation. The right ventricular size is normal and the RV function is normal to mildly reduced. Mr. C undergoes pulmonary artery catheter placement and hemodynamics are seen here. The RA pressure is 10, pulmonary artery pressure is 50/24, pulmonary capillary wedge pressure is 24 with a cardiac index of 1.4, and the SVR is 1428. Pause the video here to think about how you would qualify this patient's shock, right or left-sided dominant. How would you frame this patient's current clinical status? The patient has left-sided dominant cardiogenic shock as evidenced by the elevated wedge pressure. He is SCAI stage C with acute MI cardiogenic shock. There are different support options, but for the purpose of our discussion, a balloon pump is trialed. Repeat hemodynamic numbers show fairly minimal improvement with a right atrial pressure of 8, a pulmonary artery pressure of 48/20, pulmonary capillary wedge pressure is 20 with a cardiac index of 1.6 and an SVR of 1300. He continues to require norepinephrine to maintain a MAP of greater than 65. His repeat lactate has come down to 3 but remains mildly elevated, and urine output is slightly better but remains low at 35 cc's per hour. Overall, Mr. C has had some mild improvement in his shock but remains tenuous and has not had a dramatic hemodynamic improvement with balloon pump support. Compared to our first patient, who also had LV dominant failure, why has Mr. C not responded as well to balloon counterpulsation? To understand this better, let's focus on the third pillar of balloon pump responders, cardiac output reserve with afterload reduction. An important parameter to discuss in this case is left ventricular cardiac power. LV cardiac power is a quantitative measure of the heart's hydraulic pumping capacity. How much blood volume is the left ventricle moving at what pressure? LV cardiac power index is calculated by multiplying the cardiac index, a metric of how much blood volume the heart is pumping, by the MAP, which is the mean pressure that the heart is generating in the systemic arterial system. Dividing by 451 is a constant in the formula to convert cardiac power into watts. The higher the LV cardiac power index, the more work the heart is doing, i.e., the stronger it is pumping. For Mr. C, the LV cardiac power upon presentation equals MAP, 60 millimeters per mercury times the cardiac index, 1.4 liters per minute, divided by 451, which equals 0.19, which is very low. For patients presenting with cardiogenic shock, a LV cardiac power less than 0.3 to 0.5 is associated with higher in-hospital mortality. Patients with very low cardiac power may have minimal contractile reserve to respond to balloon counterpulsation. We must also consider the clinical context and the insult that the heart received. Mr. C came in with a late presenting anterior myocardial infarction. So, even though he had revascularization of the LAD, he has probably sustained some major permanent infarction of the anterior wall. Those myocardial segments will probably not be able to increase their contractile function in response to lower afterload or increased coronary perfusion pressure. Furthermore, his left ventricle is not dilated, there is minimal mitral regurgitation, and the SVR is only mildly elevated. All parameters that portend minimal improvement with the afterload reduction provided by balloon pumping. All of these factors contribute to Mr. C having a fairly minimal improvement after balloon pump placement. He might benefit more from a percutaneous transvalvular left ventricular assist device, such as a left-sided Impella, which would directly increase his left-sided cardiac output and help to reduce left heart filling pressures. In summary, today we went over 3 cases. Mr. A with acute on-chronic heart failure shock with severe functional mitral regurgitation and dilated LV with robust positive response to balloon pump support. Miss B with biventricular cardiogenic shock associated with myocarditis with poor response to balloon pump support given density of shock and the left and right-sided heart failure. And Mr. C with late presenting acute myocardial infarction shock with low cardiac power and minimal left ventricular contractile reserve and thus minimal improvement with balloon pump. Overall, general factors that are associated with improvement in hemodynamics with balloon support that should be considered for your patients include acute on-chronic heart failure, a dilated left ventricle greater than 6 centimeters, significant functional mitral regurgitation, and preserved or elevated systemic vascular resistance. That wraps up this video. Thanks for tuning in.